I would like to address another relatively unresolved issue, and that is neoplastic disease in the cervical spine. And again, there are three main challenges that we can identify. There's a mechanical one in that the cervical spine is quite vulnerable to lytic disease processes in terms of losing its basic biomechanical functions. There's a biological component in that these people are obviously very ill, and age comes into play, disease progression comes into play, the type of treatment rendered, whether it's radiation or chemotherapy or any combination thereof, and the osteopenia that it leads to in the end, as well as a deformity that may result from a variety of measures or inactivity. And finally, but certainly not last, we have the spinal cord dysfunction, which can obviously be adversely affected due to space-occupying lesions or malalignment. The symptoms are notoriously vague. Patients can present with back pain or neck pain. They have a history of prior malignancy, and at 70% of all cases, they present with some degree of weakness. And it's a progressive, unrelenting pain, as you know. The potential sources of pain are multifocal. It can be due to a pathologic fracture, it can be microfractures of weakened bone, a distortion of the periosteum with a tensioning phenomenon, it can be instability, or it can actually be compression of neural elements. If we differentiate primary from secondary spine tumors, the primary spine tumors are truly a rarity. Primary bone tumors are only 0.4% of all tumors, and primary spine tumors encompass about 4% of all primary bone tumors. And you can see a listing in this diagram here on the right-hand side with osteoid osteoma and osteoblastoma and aneurysmal bone cyst being by far the most common, followed by giant cell tumors. The metastatic disease itself affecting the spine compromises 98% of spine tumors, and there are estimates that up to about 60 to 80% of all patients with metastatic tumor disease will have some form of a disease dissemination into the spinal column. And the most common diseases that metastasize to the spine are listed here. On the right-hand column, myeloma, lymphomas, lung and breast disease. On the right-hand side, prostate, kidney, colon, and thyroid disease. Interestingly, with modern care rendered by our hematology and oncology colleagues, the survival rates of some tumors, even in the 3-year category, has improved dramatically, such as especially for patients with breast disease, prostate disease, and even renal disease. So we cannot use simple estimates anymore as to patients having a very limited outlook after being afflicted with this horrendous disease process. The workup is very clear and very straightforward. Again, plain radiographs, even in the cervical spine, allow an 80 to 90% of patients a very clear identification of a lytic disease process going on. However, it does require about 30 to 50% of bone loss at that segment to become pathologic. Obviously, once there's a suspicion of a disease process going on, we will always obtain an MRI scan as well as a CT scan to evaluate both soft tissue component as well as bony destruction. And we need both entities to make up our mind and come up with a good treatment plan. The differential diagnosis is obvious to this audience here. It consists of infection, primary spine tumors. Osteoporotic lesions can be quite difficult to differentiate, hematoma and inflammatory disease processes. The staging studies are very important and an integral part and should be routinely obtained in virtually all disease processes. It involves a bone scan to assess the lesion and to look for other sites of involvement. And it looks for a skeletal survey in those lesions that we know to be metabolically very active and highly destructive, in which case the bone scan, the standard technetium-99 bone scan, may be false negative. So if you have a highly destructive lesion, do not be surprised, such as a multiple myeloma, that the bone scan gives you a false negative reading, and a plain X-ray or a CT scan will show you a positive disease process. The further staging studies obviously should include a head CT, chest and abdominal CT with contrast, angiography where needed and a vascular disease is encountered, and a needle biopsy as needed or an open biopsy in case of an inaccessible or a unyielding needle biopsy tract. The staging disease is very similar to the thoracolumbar spine, and again differentiates between benign, locally potentially aggressive disease processes, such as seen in the stages 1 through 3 in the top row, and malignant disease processes in which either a confined disease process is present within the vertebral body or usually at the junction of the pedicle to the vertebral body, or in which case there's a penetration of the lesion from the vertebral body into the surrounding soft tissues, which is obviously a far more malignant and destructive disease process. Weinstein has suggested a staging system for the thoracolumbar spine, which essentially divides in an axial plane the spine into 12 different sectors. And basically, in a very simplistic rendition of this, if you have 3 or 4 of these sectors destroyed, there's a high chance of failure of the spine. And this can actually be very nicely extrapolated to the cervical spine as well, using again this clockwise configuration. And you can literally draw that out in your office to calculate whether a cervical spine is going to be more likely than not to be prone to failure in presence of a lytic disease process. The principles of treatment should really be applied uniformly throughout all physicians who participate in the care of patients with oncologic disease processes. And that includes to identify neurologic deficits. So instead of just looking at a patient's cell counts, I think it is very important that we do ask our colleagues who are participating in the oncologic care primarily to also be aware of the neurologic status of patients and preferably avoid the evolution of significant neurologic deficits. We should identify whether the lesion is primary or metastatic in nature and identify tissue diagnoses if possible. We should, by assessment of our CT scan, for instance, identify the tumor behavior by virtue of the host response. Does the host have a chance to respond to this tumor, indicating a slower disease process, or is the host overwhelmed by the aggressiveness of the tumor? And we should obviously look at the patient's general health. And there are a variety of parameters to look at that, whether it's a nutritional assessment with albumin, a weight or a body mass assessment. Those are very simple ways to look at it. Simple weight loss or skin fold measurements can be used as well. From a spine standpoint, and not just from a spine standpoint, but from a basic assessment of quality of life standpoint, patients should be asking to have their present neurologic function either preserved or improved if diminished, and we should try to relieve pain. So far, unfortunately, in the presence of metastatic disease, we cannot talk about an actual disease control with this, but a quality of life improvement, although a very significant fraction, is what we're really after. The non-operative measures are in part effective and in part probably ineffective. Bracing, for instance, in a patient with metastatic neoplastic disease is probably very difficult to enforce and to enact process unless there is a conversion of a radiosensitive tumor tissue to a blastic lesion. Radiation, again, is an often held knee-jerk reflex to a lot of metastatic disease. The question of timing and surgical intervention should be raised very critically. Chemotherapy and analgesic therapy round out the non-operative disease management spectrum. Basically, on a simplistic basis, we can differentiate into radiosensitive tumors and less effective lesions. The effective management treatments are lymphoma, myeloma, leukemia, and prostate, in which one can actually achieve amazing responses with radiation treatment. Radiation treatment, I think, is safe to say, and I'm not a radiation oncologist, so with due deference to my radiation oncology colleagues, I'll say this. GI lesions and renal cell, for instance, is very radio insensitive and is probably a waste of time for most patients. The natural course history of most patients is that the majority of patients who are intact at first presentation, upon implementation of proper treatment, will remain, however, intact. Paraparetic patients, however, have an about a third to two-thirds chance of regaining ambulation after institution of treatment. And only one-third of patients who have a significant neurologic deficit will regain ambulatory potential. So basically, in a nutshell and in a simplification, one can say that patients should preferably not be allowed to develop a neurologic deficit to maintain good and dignified quality of life. Again, the fracture risk is one that is very closely correlated to the amount of lytic disease looking at an axial cross-section of the spine, and this is where CT scan is so much more important than an MRI scan to essentially try to quantify the disease process. And once a facet joint Once about a third to half of the vertebral body is diseased with a lytic process, it is safe to say that that segment will probably collapse unless it's a very radiosensitive lesion. Again, we've talked about this right now, so I'll fast forward through this. In surgery, the tumor control is again not a surgical goal. We have to essentially acknowledge that our surgical interventions are an intralesional surgery. It's not a truly radical surgery. And there are certain disease processes where we can actually perform a wide excision, and this is what I want to focus on a little bit in the cervical spine. The surgical approaches are somewhat dictated by the location of the lesions. In the upper cervical spine, an anterior approach is pretty impractical, and we usually are confined to a posterior procedure in which we try to achieve a craniocervical stabilization. However, anterior and posterior combined approaches do allow for a very wide excision of a tumor mass if a longer survival of a patient is realistic, and it actually makes a whole lot of sense. Just in terms of terminology, we should use our words carefully. A curettage is essentially a piecemeal removal of a tumor, and it's certainly an intralesional or partial excision. An en bloc resection attempts to remove the whole tumor in one piece, however, is not radical. Radical means that the whole compartment with the enveloping soft tissues around it is removed. And again, this is simply impractical in the spine, unfortunately. A palliative procedure, again, pursues a functional purpose, such as cord decompression and realignment of a fracture. Again, the vast majority of patients who have metastatic disease have an anterior compression of their spinal column. So that brings most of us to instinctively think that we should perform an anterior procedure in the cervical spine, such as a corpectomy. We do have to acknowledge, however, that a corpectomy usually will not address the pedicle or the facet joint involvement. And again, this is where our Japanese colleagues have deserved a lot of credit, because they have developed this essentially en bloc posterior resection technique, where the posterior elements of the spine are disarticulated as a first step procedure through the pedicles. So the facet joints are resected, the lamina is resected, and it's actually a very straightforward procedure. There's no attempt made at removing what seems to be the majority of the disease mass anteriorly. By performing this first, then, as a second stage procedure, the anterior vertebral body can be removed through an amazingly simple procedure and without much destruction of surrounding soft tissues. The same, by the way, goes and holds true for the thoracolumbar spine. This is an applicable case of a 22-year-old patient with an osteosarcoma that involved the lateral masses as seen in the top left-hand parasagittal CT scan. Embolization, as you can see, of the vertebral artery is performed from cranial and caudal. After trial balloon embolization had verified that adequate perfusion of the cerebrum would be maintained. And initially a posterior resection was carried out, and then an anterior en bloc resection through the far side of the vertebral body was carried out with essentially a very nice removal of the tumor in a hole. We followed this patient now for 6 years with regular CT scans, which is one of those, and you can see that the allograft has healed in very nicely, and the patient has fused, and there's no evidence of disease recurrence, I'm happy to report. Again, we used a multi-segmental posterior fixation with a construct that you're familiar with, a rod plate, and we're very pleased with the integration. Again, structural allograft and rigid fixation are very suitable tools for an immediate stability, and we very much try to not use braces or external immobilization devices in these patients to afford maximum quality of life. There have been suggestions to perform a sagittal resection where you can essentially cut the spine from front and back, but we found this to be quite cumbersome and have essentially abandoned this particular strategy. In the upper thoracic spine, and again we have to remember that a lot of these metastatic lesions seem to focus for probably circulatory reasons around T1 and T2, the different strategy can be employed, and that is that of a coster transresectomy, where essentially a large lytic lesion is approached from the side of the larger lesion, and in this case the left-hand side, and through a posterolateral approach, which is extracavitary in nature, the tumor mass can be removed and can be replaced with a cage. This is a case of Dr. Shaffrey's, which had a very satisfactory outcome. I think it was a renal cell CA with primary embolization first. Radiation prior to surgery is one of those big problems that we as surgeons face very frequently, because without a question the incidence of infections after surgery done through a posterior approach rises significantly in a radiated field. Again, we should very much try to include our radiation oncology colleagues in the conversation about treatment, and hopefully can take a more active and integrated role in the tumor management of these patients in the future.